Every morning, somewhere between brushing your teeth and making your coffee, you do something that takes about 4 seconds. You open a small bottle, shake out one pill, and swallow it. And then you move on with your day, because as far as you know, the job is done. Your doctor told you your blood pressure is controlled. Your numbers look acceptable. You are doing what you are supposed to do. The prescription is filled. The pill is taken. The problem is managed. I need to tell you something today that your doctor almost certainly has not had time to explain clearly. And I do not say that as a criticism of your doctor. I say it because the appointment that ends with a blood pressure prescription is typically 7 to 12 minutes long, and what I am about to explain to you takes longer than that to say properly. Controlled blood pressure is not the same thing as reversed hypertension. That distinction, for words on each side, is the most important thing I am going to say in this entire video, so I want you to sit with it for a moment before we go further. Controlled blood pressure means your medication has successfully reduced the number on the monitor to an acceptable range. Reversed hypertension means the biological processes driving that pressure up in the first place have been addressed. These are not the same thing, and in the vast majority of people taking blood pressure medication today, one has happened and the other has not. The number looks fine. The disease is still progressing, and nobody told them. My name is Dr. Sarah Monroe. I spent 12 years in internal medicine, and the conversation I had more than almost any other, the conversation I never had enough time to have the way it deserved to be had, was this one. The patient sitting across from me who had been on antihypertensives for 5, 10, sometimes 20 years, whose blood pressure was technically controlled, who was also quietly developing the kidney dysfunction, the arterial stiffening, the cognitive decline, the left ventricular changes that hypertension drives even when the number on the monitor looks fine, because their medication was doing exactly what it was designed to do, and only that. Today I am going to walk you through what your blood pressure medication is actually doing inside your body, what it is not doing and was never designed to do, the 3 root-level biological processes that drive hypertension that no blood pressure medication directly addresses, and exactly what you can add alongside your medication to begin addressing those root causes. Nothing in this video is a suggestion to stop or reduce your medication, not for a single day, ever without your doctor's guidance. What this video is a conversation you deserve to have the day your prescription was written. Let us have it now. To understand why medication alone is not enough, you need to understand what blood pressure medication actually does. There are several major classes of blood pressure drugs, and each one targets a specific downstream mechanism. I want to walk you through the most common ones clearly. ACE inhibitors and ARBs, drugs like lisinopril, ramipril, losartan, work by blocking the renin-angiotensin-aldosterone system, the RAS. This is a hormonal cascade I described in my kidney health video on this channel. The emergency pressure management system your body activates when it senses low blood volume or low blood pressure. By blocking angiotensin, these drugs prevent blood vessels from constricting and prevent the kidneys from retaining excess sodium. The result is lower pressure. They do this very effectively. What they do not do is address why the RAS was chronically overactivated in the first place. Beta blockers, drugs like atenolol, metoprolol, bisoprolol, reduce heart rate and the force of cardiac contraction, which lowers the amount of blood pumped with each beat. Lower output means lower pressure. Again, highly effective at what they target. They do not address why cardiac output was elevated. They do not address the metabolic drivers. They slow the heart. They do not heal the system. Calcium channel blockers, drugs like imlodipine, relax the smooth muscle and arterial walls, causing blood vessels to widen and resistance to fall. Blood pressure drops. But the arterial walls themselves, their stiffness, their inflammatory state, their endothelial health are not changed by the drug. The vessel is forcibly relaxed. It is not biologically repaired. Diuretics, drugs like hydrochlorothiazide, indapamide, force the kidneys to excrete more sodium and water, reducing blood volume. Lower volume in the same circulatory space means lower pressure. But they do not address why the kidneys were retaining excess sodium in the first place. Every one of these medications is valuable. Every one is potentially life-saving. Uncontrolled hypertension causes strokes, heart attacks, kidney failure, and dementia rates that are devastating and entirely preventable with treatment. I am not questioning the value of these drugs. I am asking you to understand precisely what they do. Because only when you understand what they do can you understand what they do not do. And what none of them do is address the 3 upstream biological processes that caused your blood pressure to rise in the first place. The first upstream process that medication does not reverse is insulin resistance, and its effect on the kidneys. As Dr. Alex explained powerfully in his blood pressure content, and as I have covered across multiple videos on this channel, Insulin is not only a blood sugar hormone, it is also a sodium-retaining hormone. When insulin sensitivity declines, a process that affects a majority of adults over 40, often without any formal diabetes diagnosis, the pancreas must produce progressively more insulin to move glucose into cells. That chronically elevated insulin signals the kidneys to retain sodium, and wherever sodium goes, water follows. Blood volume rises. Pressure rises. Your blood pressure medication addresses a risen pressure. Your beta blocker slows your heart. Your diuretic removes some of the excess sodium, but your insulin levels are still elevated. The signal to retain sodium is still being sent every day. The medication is bailing water from a bowl with a hole in it effectively, necessarily, importantly, but the hole is still there. The dietary pattern that drives insulin resistance, refined carbohydrates, added sugars, insufficient fiber, ultra-processed food, continues to send that sodium-retaining hormonal signal every single day, regardless of what medication you take. And that signal does not just raise blood pressure. It drives the inflammatory processes that stiffen arterial walls over time, contributes to kidney filtration pressure, and accelerates the vascular damage that hypertension is famous for causing. Medication lowers the pressure number. Insulin resistance continues the disease process beneath it. The second upstream process that medication cannot reverse is endothelial dysfunction. The endothelium is a single-cell thick lining of every blood vessel in your body. In a healthy state, endothelial cells produce nitric oxide, a molecule that signals the smooth muscle surrounding blood vessels to relax, keeping them flexible, compliant, and able to dilate in response to the body's changing needs. Nitric oxide is the body's own natural vasodilator. When endothelial function is healthy, blood vessels behave like elastic tubes that expand and contract smoothly. When endothelial function is impaired, through oxidative stress, chronic inflammation, insulin resistance, smoking, or a poor diet, nitric oxide production falls, vessels stiffen, resistance rises, blood pressure climbs. Calcium channel blockers mimic the effect of nitric oxide by forcing arterial smooth muscle to relax. But the endothelium itself is not repaired by any blood pressure medication. The capacity to produce nitric oxide on demand, the biological flexibility of your blood vessels, is not restored by the pill. This matters enormously because arterial stiffness is an independent cardiovascular risk factor. Beyond blood pressure, stiff arteries increase the work the heart must do with each beat, damage the small vessels in the brain and kidneys through pressure waves they cannot absorb, and progress over time toward the end-stage organ damage that hypertension ultimately causes. Medication controls the number. Arterial stiffness continues. The third upstream process is chronic systemic inflammation and its effect on vascular architecture. I have covered inflammation extensively across previous videos on this channel, its drivers, its hidden food sources, its connection to gut health, liver function, brain fog, and kidney damage. Every one of those connections runs through the blood vessels. Chronic inflammatory cytokines, TNF-alpha, interleukin-6, C-reactive protein, cause direct structural changes to arterial walls. They promote the oxidation of LDL cholesterol and its deposition into arterial walls as plaques. They impair endothelial function and reduce nitric oxide availability. They activate the RAS. They make arteries stiffer, narrower, and more vulnerable to the events, rupture, clot, occlusion, that cause strokes and heart attacks. No blood pressure medication reduces systemic inflammation. Statins, which are often prescribed alongside antihypertensives, have some anti-inflammatory effect as a secondary property, but that is a separate drug and its primary purpose is cholesterol, not inflammation. The inflammatory load driving your arterial deterioration continues regardless of what your blood pressure reading says on the monitor. 3 root causes: insulin resistance, endothelial dysfunction, chronic inflammation. Your medication addresses none of them directly. It addresses their downstream consequence, elevated pressure, with remarkable effectiveness. But the river keeps flowing even when you dam it. And the dam, your medication, requires consistent maintenance while the pressure upstream continues to build. So what actually addresses these root causes? What can you add alongside your medication that begins to work at the level the medication cannot reach? The first and most powerful intervention for insulin resistance is dietary fiber, and the restructuring of carbohydrate quality in your diet. I covered this in detail in my gut health video, but the cardiovascular implications are specific and significant. Dietary fiber slows glucose absorption, flattens the post-meal insulin spike, and over time, through its prebiotic effect on the gut microbiome, improves systemic insulin sensitivity. Research published in the British Medical Journal found that high dietary fiber intake was associated with significant reductions in blood pressure independent Of other dietary factors, the mechanism runs directly through insulin. Less post-meal insulin means less renal sodium retention, means lower blood volume and lower pressure. This is not fiber making you generally healthier in some vague sense. It is fiber reducing the specific hormonal signal that your kidneys use to retain sodium. 30 grams of dietary fiber per day from diverse whole plant sources is the evidence-based target. Most adults consuming a typical Western diet get fewer than 15. The second intervention is aerobic exercise, specifically the form that most directly stimulates endothelial nitric oxide production. When you exercise aerobically, brisk walking, cycling, swimming, the increased blood flow creates what physiologists call shear stress on the inner walls of your blood vessels. That mechanical force stimulates endothelial cells to produce nitric oxide, not just during the session, for hours afterward. Research published in the journal Hypertension found that regular aerobic exercise reduced systolic blood pressure by an average of 5 to 8 millimeters of mercury, an effect comparable to some antihypertensive medications through the nitric oxide pathway. Specifically, and crucially, unlike medication, regular exercise also reverses endothelial dysfunction over time. It does not just mimic the effect of nitric oxide, it restores the machinery that produces it. 30 minutes of brisk walking 5 days per week is a minimum effective dose for someone already on medication whose numbers are controlled. This addition can be discussed with their doctor as a pathway toward potentially reducing dosage over time, never eliminating it unilaterally, but working toward a biology that requires less pharmaceutical support. The third intervention addresses chronic inflammation through the dietary pattern, most consistently associated with reduced inflammatory markers and improved vascular health. The Mediterranean-style dietary pattern, rich in olive oil, oily fish, vegetables, legumes, nuts, and whole grains, has been studied in the landmark PARADIGM trial, one of the largest nutritional intervention studies ever conducted. It found that a Mediterranean diet supplemented with extra virgin olive oil or mixed nuts significantly reduced cardiovascular events including stroke and heart attack. Independently of blood pressure changes, the mechanism runs through multiple pathways simultaneously. Polyphenols and olive oil improve endothelial function. Omega-3 fatty acids from oily fish reduce inflammatory cytokine production. The high fiber content improves insulin sensitivity, and the overall antioxidant load reduces the oxidative stress that damages endothelial cells. This is not one nutrient doing one thing, it is a dietary pattern addressing all 3 upstream drivers simultaneously. The fourth intervention is sleep, specifically the quality and duration of sleep, in a way that directly affects the cortisol-blood pressure relationship. As I covered in my morning routine video and my bedtime habits video, poor sleep elevates cortisol. Cortisol activates the sympathetic nervous system, increases heart rate, promotes vasoconstriction, and raises blood pressure, both acutely during the night of poor sleep and persistently through the following day. Research published in the journal Sleep found that insomnia was associated with a significantly elevated risk of hypertension incidence and with poorer blood pressure control in already medicated patients. 7 to 9 hours of high-quality sleep is not a lifestyle luxury. For someone with hypertension, it is a cardiovascular intervention. The cortisol normalization that comes with consistent restorative sleep reduces a sympathetic nervous system activation that keeps blood pressure elevated above what medication alone can bring down. The fifth intervention is potassium, specifically the ratio of potassium to sodium in your diet, which is one of the most underappreciated levers of blood pressure regulation available to you. The kidney's handling of blood pressure is governed not just by absolute sodium intake, but by the relative balance between sodium and potassium. Potassium activates cellular mechanisms that increase sodium excretion by the kidneys. It essentially does the opposite of what insulin resistance does, telling the kidneys to release the sodium they have been holding. The DASH diet, dietary approaches to stop hypertension, was specifically designed around this potassium-sodium ratio, and research consistently shows it reduces blood pressure by 4 to 11 millimeters of mercury in treated hypertensive patients, on top of whatever their medication is already achieving. The foods richest in potassium are leafy greens, avocados, sweet potatoes, bananas, legumes, and low-fat dairy. They are also among the most fiber-rich and anti-inflammatory foods available. In a single dietary shift, you address insulin sensitivity, potassium-sodium balance, and inflammatory load simultaneously. Let me now say something clearly, because I know what question is forming in your mind as you hear all of this. If I do these things, the fiber, the exercise, the sleep, the dietary pattern, the potassium, does that mean I can stop my medication? The answer is no. Not unilaterally. Not without your doctor's guidance, and without systematic blood pressure monitoring over time. What these interventions can do when applied consistently is improve the underlying biology that your medication is working against. They can make your medication more effective. They can, in some cases with consistent effort and time, create the conditions under which your doctor may feel comfortable reducing your dose. There are people who have achieved this. It requires sustained lifestyle change, regular medical monitoring, and physician partnership. It is a goal worth working toward, not a justification for skipping doses today. What I want you to leave this video understanding is this: taking your medication and doing nothing else is treating a symptom. Taking your medication and systematically addressing insulin resistance, endothelial dysfunction, and chronic inflammation is treating the disease. Both are necessary. One is not enough without the other. You have been told half the story for however many years you have been on this pill. Now you have the other half. I want to hear from you in the comments. Tell me how long you have been on blood pressure medication, and whether anyone has ever explained to you the difference between controlled and reversed. Your answer will tell me how well this information is reaching the people who need it most. And if someone in your life is on blood pressure medication and has never heard what I just explained, please share this video with them today. It may be the most important thing they watch this year. If you are not yet subscribed to this channel, please do that now. We are building a complete, science-grounded picture of how your body's systems work together and how to protect them intelligently, not just manage them pharmacologically. There is more coming, and it connects to everything we have already covered. I am Dr. Sarah Monroe. Your medication is doing its job. Now it is time to do yours.